Still have an
Still
echo.
have an echo.
It will toggle to whoever is speaking. I might just have it.
What? Your face is kind of covered. Do you want me to redo it?
Okay, let's just give it a minute. I'm just going to get the Q&A tested.
Okay.
So I'm not echoing for you.
No, you're not echoing for me.
Okay, then I might just have to deal with it.
It's annoying, I know, but no, you're not echoing for me.
Okay.
Oh, this can be. We put that in the garbage. Thank you.
Okay, just give me one.
You're totally fine. I need to turn off that sound. Shh.
Okay, everybody else is saying that there is an echo for them, which is not ideal. And that has okay. I'm echoing for all of them.
Do you think it's me?
No. Let me try from the computer. Sorry guys, just bear with us. This has never happened before. Okay. Still echoing. I'm trying to see if I can log in. Try to count. I'm going to try from my phone. Wait, do you hear me, Rachel? Okay. Nope. I have yeah. Okay. I'm going to try to on my phone. Rachel, why don't you go ahead and just get started with production and what you do and how people work with you, what the setup is, try to log in.
Okay, not a problem. Hi guys, I'm Rachel. I'm a physician assistant and my background is in neurology. I specialized in Parkinson's disease for 8 years and I kind of got a little burnt out and also was always really interested in the functional, like medicine, holistic health space and how to prevent the chronic diseases from happening. And so after my second baby, I decided to kind of take a leap and I've been doing functional medicine work for about the last 3 years. And my latest venture is I am working out of Be Well Lifestyle Centers in Birmingham, Michigan. And so, a little bit about what I do. I do focus on like the perimenopausal woman, but that's not like my exact niche. I see men, I see teenagers, I see elderly people. I work on hormone replacement therapy, weight loss. I do all the peptides and like supplement recommendations.
Okay. I feel like because it keeps toggling back to you, it's something happening on your side. So I don't know what we can do on your end. Can you mute yourself for a second and let me see if that is the issue? Okay. Because I'm not hearing an echo right now when you're muted. So is there something with your setup? Like are you just on your computer? Do you have a separate mic plugged in? Okay.
Is it echoing when I talk?
No. It's just when you're unmuted and I'm talking. So
I can just mute it when you're talking.
that's probably what we have to do. Sorry. I don't know why it's doing that and I can't wherever I try to log in, I'm getting an issue. So I'm sorry about that, guys. Okay. So thank you, Rachel, for that intro. All right, let's jump in. So we are going to be covering basically peptide therapy in general. And thank you everybody for joining. There is a Q&A section at the bottom. If you're joining from your phone, it's the little kind of QA at the bottom. There is an option to ask anonymously. So you can go ahead and do that through the anonymous feature, because I know we are going to be talking about some sensitive topics today, especially when it comes to GLP-1s. If you do not want to be public for those questions, or even if you don't ask anonymously, if you ask within the chat, I'm not going to say anybody's name with it, given the nature of the conversation today. So I'm really excited to have Rachel here. I first want to talk a little bit about peptide therapy in general. Then we will get more into the GLP-1s because GLP-1 is peptide therapy. So we'll kind of dive down a little bit deeper into GLP-1s. And then from there, we're going to cover BHRT. So that's kind of our outline for today. Please feel free to ask questions all throughout. And I'll answer them as they come in whenever there's a break in the conversation. But without further ado, we will jump in. Rachel had given us her background and shared with us. I was so happy when she agreed to come on here. So first and foremost, can you just start with the basics? Like, what are peptides? Help us understand, like, are they natural? Like, how are they administered? I'll kind of jump in with some follow-up questions, but if you can just kind of start with the basics of what are peptides and why are we hearing so much about them now?
For sure, and I'm really excited to be here too. I didn't mention that before. Okay, so peptides are getting a lot of hype in the media, and everyone's talking about them. And so, what they are short chain amino acids. So, without getting too scientific, amino acids, when you have less than 20 amino acids and your body has amino acids, greater than 20 amino acids make a protein. So, short chain amino acids are basically the building blocks for proteins. And peptides take these short chain amino acids and they put them in different variations and they make these peptides. And by taking the peptides, you're just refueling or refilling your body with these amino acids that we have, and they target different things. Most peptides are done injectable because that is the most that's the best way to do it. There are a little, like, there are a couple that are actually okay to be taken as a pill, ones that help with the gut, and there's some that you can put on your face to help with skin elasticity, collagen, stuff like that. But for the most part, injecting peptides is the most useful way.
Okay,
Okay,
so
so
why are we hearing so much about them now? And I know a lot of people have questions about, and maybe it's just in my circles, but it just seems like this has like taken off in the last like few years. Is it just kind of the GLP-1s that have like introduced people to more of like all of the peptide therapy available? Like, is there something that changed kind of from a regulatory standpoint? Like, I know most of them are still not FDA approved. So can you help us give us a little bit insight into like why it's such a big topic right now?
So I do think that the GLP-1s have really like brought a lot more attention to peptides in general. So the GLP-1s being semaglutide, tirzepatide are considered peptides. And however, in the past, peptides have been really popular to like wellness people, biohackers, longevity people. So, people who have been looking at like ways to live the healthiest life for the longest period of time. And since the GLP-1s have kind of blown up for a lot more than just weight loss, now a lot of people are looking at peptides in general and what that can do for them. And then the media, celebrities, famous people, they all just are on this peptide bandwagon, which I think is a great bandwagon because the truth of the matter is they do amazing things.
I mean, agreed. I've been on some myself, which we'll get into, but what do you feel like, I mean, is there anybody that should not be taking peptides? And I mean, we'll obviously dive into GLP-1, so maybe there's a specific answer to that, but in terms of some of these other peptides, is there just like a general statement in terms of people who should not look into really peptide therapy? And also, I think you and I have discussed before, like at what point do you take peptides? Like, let's say you're trying to heal from something specifically. Are the peptides like the first step that you would go to? Or is it something that you kind of bring in more toward the end to kind of reinforce a lot of the healing that you've done and to kind of stay in a good place? Like, if kind of a two-part question in that regard.
So the first thing is peptides are not for everyone. So like main contraindications I would say is like if you're pregnant, breastfeeding, if you have active cancer, because a lot of this is like getting your body to work better. So in doing so, like all your cells are working better. So if you do have active cancer, I wouldn't mess with peptides. Also, if you have autoimmune disease, there's a bunch of peptides that are really great for autoimmune disease. But if you're having like a severe flare, that's where having an educated provider to make sure that you're doing the right things so that we don't make those flares worse. Another big thing about peptides is that peptides are not the end all be all. Like you have to put the work in. If you just take a peptide, and you don't work out, you don't eat healthy, your lifestyle is bad habits, like peptides really aren't going to do anything. They're an adjunctive therapy to doing the key, like healthy lifestyle habits. I don't know if I answered your second part. I already forgot.
Yeah, no, I mean, I wanted to go into a little bit like when to take them, which you did with like autoimmune. Like, for example, like when I was healing my gut, it wasn't the first like BPC 157 as an example. It's one that most people probably know about. It's kind of the, introductory peptide for a lot of people. And I feel like you hear about it either for injury healing or for gut healing, like recovery. But the way it was kind of presented to me was it was better to use it like same how we talked about L-glutamine on a previous live stream. You can't just come in with a peptide and expect to heal everything. It might help with like the BPC, for example, but you need to make sure foundationally you're in a good place before you come in with the BPC over top, right? Like if you have overgrowth of bad bacteria in your gut and you try to like the BPC 157 bringing that in, that's not necessarily going to get rid of the bad bacteria, right? So just kind of, I think to your point, it's really good to work with a skilled provider, especially because there are so many online providers for these peptides, and it's hard to navigate which one is right for you. And they're not cheap, right? Like if you're getting the right protocol, you're going to be spending a little bit. It's worth it in the end to make sure you're getting a high quality product, but you want to make sure that you're getting the best product for what you're trying to address. So
for sure. Like if we talk about gut health, I mean, first of all, you shouldn't just be blindly taking peptides because you saw it on an Instagram ad. So, blood work, stool testing, and, starting to heal the gut with other modes. So, different supplements, probiotics, prebiotics, and reducing inflammation. And then adding in the peptide will just help make all of that work better and kind of seal the deal, for a lack of better terms.
yeah, definitely. And I saw that even just like I said in my own personal experience, and I feel 1,000 times better. And I feel like it was equally what I did in the beginning to heal, to fix the issues, and then the peptides to come in and kind of seal the deal, literally and figuratively. So yeah, I completely agree with that. So before we get into the GLP-1s, one more thing on just general peptide therapy. Sorry, two-part question again, which I'm doing because we have to keep doing this mute unmute dance. When it comes to the peptides, can you speak one to this whole research grade versus compounding pharmacies? And that gets a little bit into the nitty gritty for some people, but just so people are aware, kind of just to preempt that question, right now, for those of you that don't know, peptides are kind of in this state where they're like not entirely FDA approved. So in order to be sold on certain websites, like direct to consumer, they're kind of sold as research products. And so you might have to reconstitute them yourselves. You might get a powder and you have to like reconstitute them with a special bacteriostatic water. And so you're kind of becoming a chemist at home, or you can order from a compounding pharmacy. If you're working through somebody like Rachel or a provider, they place the order for you and then it gets sent to your house. So if you can just kind of explain a little bit the difference between that, Rachel, and just kind of like why it has to be that way. And then the second part of that question, which is like not entirely related, but just how people take peptides. Like, is this something that they get on and they stay on for an extended period of time? Is there a certain period of time that you like to see people on them? And then, in certain like 3-month cycles, and then they do it a couple times a year. So first part is research versus compound. And second part is like, how long are people on these and how many can you be on at a time?
Okay, great question. So let's talk about the research versus the compounding. So a compounded peptide comes from like a compounding pharmacy, and it's sterile and tested by scientists, and technically you need like a prescription to get that peptide. Now, so having a compounded pharmacy peptide's great, and then there's research peptides. Now, I'm not totally opposed to research peptides. However, when you just go online and you buy a peptide, a lot of times these peptides are not made in the US. There's no like sterility, there's no testing. You don't know what you're getting. So, working with a provider like that in person or virtually, but someone credible to know that like if you're going to use a research peptide, it is what it's supposed to be. It's tested, it was vetted by the provider, it's made in America, not overseas in China, is important. And the reconstitution part, so I do kind of a mix of both in my own practice. I get a lot from compounding pharmacy, and I have a very trusted research place that I use, that they make them like in-house in America. It's sterile and they've been tested and they're legit. And I usually will reconstitute them for my patients, just because when they take them home, they're usually like, it exploded or something. So I usually will reconstitute it for you just so it doesn't feel like you're being a chemist. But that's a conversation that I have with my patients, like kind of one-on-one, like when we're talking about the whole individualized plan, like what direction to go in. Another difference is the research peptides are smaller vials, so they last less time. So you may think they're cheaper than getting them from like a compounding pharmacy, but really they're not, because you need 3 of them to equal the amount that was in the vial from the compounding pharmacy. So again, having someone who's knowledgeable and knows what they're doing can kind of walk you through all of this.
Okay, and then in terms of how many you're on at like a certain time and how you kind of rotate them, like what's kind of best practice there um, in that regard?
Okay. So most peptides should be cycled. So what that means is depending on what we're working on based off your symptoms, our consult, our initial intake, I'll kind of come up with a plan for you, 6 month to a year plan, and we'll cycle on and off different peptides. So different peptides work together in conjunction, and like for example, BPC 157, if you're doing it to like heal your gut and not for an acute injury, I will usually pair that with something called KPV. I'll have you do it for 3 months, then we'll take a break, and then we'll come back. Like the growth hormone analog peptides, so ipamorelin, tesamorelin, sermorelin. Again, 3 months on, take a break for a month, then come back.
Gotcha. Okay, and we'll get into that. I mean, there's so many different peptides. I feel like most of the ones that we hear about have to do with and we won't get into like all the names just because it's a, like alphabet soup to an extent. And I think the bottom line is there's peptides that have to do with obviously gut healing, recovery from injury, inflammation, longevity, muscle retention, fat loss, cognition. If I didn't say that already, maybe I need one for cognition. um, so there's so many. There's one for immunity. I mean, as Rachel said, for treating autoimmune conditions and overactive immune system. So it's so important to work with a provider to understand, you know, what you're getting is really kind of targeted to what you need at that point in time. And I've worked with a couple providers, and it's, you know, there are differences in, like as Rachel said in the beginning, the delivery method, whether it's an oral peptide, there's some topicals, there's then the injectables. So I just would really recommend people work with somebody like Rachel to kind of understand what you need. But the whole point of this call is to understand that these options are out there, and it just so many different categories between like healing and then also optimizing, I guess, is where I would like kind of put them in those two categories. So if there's, well, you can always ask questions, guys, if you have them. But I think we'll move on at this point to GLP-1s. So GLP-1s are, of course, another type of peptide specifically targeted at kind of the GLP-1 and similar receptors in the body. So, Rachel, can we start with? I feel like a lot of people get confused on what GLP-1s are out there because now there's a new one in the marketplace. So, can you just kind of go over one, how they work? And I guess while you're going over that, can you explain like the three options? And if there's more, feel free to add, but that at least I'm aware of. And I'm sure, you know, those would be the ones that you would cover anyway, but just kind of a basic introduction to like the difference between the semaglutide and then the other ones and kind of what your preference is.
Yes, of course. So there's a lot of different GLP ones like in the category. I'm gonna focus on the three main ones. So semaglutide, tirzepatide, and the new one, retatrutide. So semaglutide is the first one to come out, branded version like Ozempic, and Wegovy. So that works on one receptor, the GLP-1 receptor, and that's a receptor that helps to control blood sugar. And in doing so, it slows down your gastric emptying, and it slows down your whole GI tract. And that means that you're going to stay full longer, and you're going to have a smaller appetite because your stomach is not emptying as much in between meals. It also works on the GLP-1 in your brain to get rid of like those hunger cues, the food noise, some like addictive properties. So that's the first one. Then they came out with tirzepatide. Tirzepatide works on two different receptors, GLP-1 and GIP. And so basically working on two different receptors that do similar things, we are amplifying that and causing an even more robust response. I also find that patients have less side effects on tirzepatide than they did on semaglutide. Side effects being those GI upset side effects from that slowing of the gastric tract. And then lastly is the new one that's not yet FDA approved, retatrutide. So there's no branded version of it yet. And that one works on 3 different receptors, GLP-1, GIP, and glucagon itself. And in doing so, it works better at losing weight, controlling blood sugars, getting rid of that food noise. There's a lot of trials right now about using GLP-1s in like addiction. Food can be an addiction for people based off of that food noise. So finding it like with alcohol and tobacco and stuff like that. So that's like a really interesting thing. Side note. And then so works on 3 receptors, and retatrutide is the most like effective, but they're saying that because it works on that glucagon, it's less likely to impact your muscle mass. So those are the 3. My try and true is tirzepatide all the way. With my background in neurology, I like the cleaner, newer drug that has a smaller side effect profile. So when we talk about semaglutide versus tirzepatide is up here for me. And then retatrutide, I've started to put patients on. I specifically am using it at the moment for patients who are not seeing effects from tirzepatide. So I tell my patients all the time, like, if it's not broken, don't try and fix it. So if tirzepatide works, stay on tirzepatide. But for those patients who tirzepatide's not doing it, that's when I go to retatrutide.
Okay, awesome. And just so people are aware, the brand names for tirzepatide are Mounjaro and Wegovy, right?
Mounjaro and Zepbound are tirzepatide.
Okay. Sorry, yeah, misspoke. So, can you, along those lines, help people understand what is the difference? Because this has been very confusing for the people that I know that have done this. What is the difference between the brand name, the compounded version? Like, in your opinion, which one is better? And then how does having a prescription or not having a prescription from your provider kind of play into that?
Okay. So, um, the difference between the branded versions is they come in specific dosages, as opposed to the compounding pharmacy. They come in a vial and they can be dosed accordingly. So I'll get into that again in a minute. But when we talk about the compounded version, basically these companies, to compound a drug that has like a patent through the FDA, you have to change it a little bit. So usually the compounded versions have something in them. I don't like the ones with B12. I like ones with like the cleanest profile. So niacinamide is usually the one that I'll use, which is just a B vitamin. But basically, when you get a branded version, it comes in certain doses. So, for example, like for Zepbound, and I could be wrong, could be Mounjaro. I get a little confused, but like the starting dose is 2.5 milligrams. I start my patients with compounded tirzepatide at a dose of 1.25, and I slowly increase your dose. And in doing so, you're less likely to get side effects. You're less likely to stop eating completely, because that's not what you want. Because if you get this rapid weight loss, you're just going to gain it back when you stop, and it's going to affect your muscle. So slow dosing, really personalized with the provider, is really important. And so I actually really like the compounded version. Now, I do have patients who do get branded versions from the pharmacy, like they get it covered through insurance. And I tell my patients, and I probably shouldn't say this on a podcast, but here I am saying it, to inject the medicine in a vial, try and keep it as sterile as possible. And then we're able to dose it starting at a microdose and like working your way up. Because, to go from 2.5 milligrams to 5 milligrams is a huge jump. And that's how the prescriptions are. What if a patient just needs 3 milligrams? So that's where the compounded kind of comes in.
Yeah, and I think that's so important because I feel like a lot of the people that I know that have done this, when they do experience side effects, it's because moved up too quickly in their dose, as you said, and then I think another big piece of it too, which is where you come in as well, is offering proper nutritional advice, right? Like making sure that you're keeping up with protein, with minerals, so that you can either avoid completely or certainly minimize any side effects in terms of, like, losing too much muscle mass or losing hair, and other things that people hear of. So is that kind of, I feel like, my impression of those side effects, because obviously we've all heard, like, people going blind using some of these GLP-1s, like, obvious stomach paralysis, pancreatitis. Like, what is your opinion on those side effects? And, is that just misuse, or are there certain people that are just more prone to it? Like, can you help kind of dispel maybe some of those misconceptions about the side effects, and where those come from?
Yes. So every medication that you take is going to have a risk for side effects. I mean, you can pull out like Tylenol, Advil, and you'll see a list that goes a mile long. Now, in terms of like these medications, um, working with a provider who is keeping track of you. So, like, I draw labs on my patients every 3 to 6 months, or they bring me labs, certain, pancreatic enzymes, liver enzymes, to make sure that they're not creeping towards pancreatitis or gallstones. And if a patient has a history of that, then I would watch that closely, even closer. I also supporting the medication with certain supplements. So to help with hair loss, when you lose weight, that's like a stress on the body. And so when that happens, a lot of people lose hair. And that's okay, but by having a supplement, we can reduce the risk and reduce that hair loss. In terms of the vision loss, it's like I meant to look up like the what the percentage was, and I did not. I'm sorry, but it is such a small percentage of patients, like such a minute risk, that with any medication, you talk with the provider, the benefits versus the risk, and you go from there. If the patient has diabetes, they are more likely to have like a diabetic retinopathy, which could lead to that blindness. So that's just, another kind of looking at the whole picture to make sure to reduce the possible risk. Now, if you're losing too much weight too quickly, I tell patients half a pound to a pound a week is perfect, because you want this to be sustainable weight loss. And in it also, you need to do it with lifestyle changes, getting your protein in. So for your ideal body weight, every pound of ideal body weight. So if your ideal body weight is 130 pounds, you should be getting 130 grams of protein, period, every single day. And if you're not, then that's not like the lifestyle that should be used with the GLP. And in not making those changes, when you go off of it, you are more likely to gain the weight. If you are rapidly losing weight, I'll have a patient come in and be like, oh, it's 25 pounds in the month. This is amazing. I'm like, that's terrible, because you just literally destroyed your muscles. And also, like, this is not sustainable weight loss. You just clearly were on too high of a dose and you weren't eating. And the second you stop, you're going to put that weight back on.
Yeah, I mean, great info. Are there other strategies or tactics that you use to help people keep the weight off, other than just like this kind of more steady pace to the weight loss, these lifestyle changes? Are there any other tools? Like, what have you seen in your practice, in terms of just success rates of people kind of coming off of some of these GLP-1s?
So exercise, strength training, so important. Making sure your hormones are optimized, especially once you're like in that perimenopause phase, is very, very critical to keeping the weight off. I have patients who love it, and I mean, I personally love it too. You just have to do it in a healthy way. You need to do it in a healthy way with healthy lifestyle, changes. So the healthy protein, working out, strength training, making sure your hormones are optimized is the way to keep the weight off.
I'll just interject with a quick question from the audience. So somebody asked if they don't live close to your clinic, like what are some things that they should look out for or avoid in a practitioner if they're considering whether it's GLP-1s or any peptide therapy?
So first of all, I do see virtual patients. I have licensure in California, New York, New Jersey, Texas, a few other states, so we can talk. But if you're looking for a provider, you need to make sure that they're asking for blood work before they start treating you, because if they're not, they're just blindly prescribing things, and that is a red flag. And then also what their follow up looks like, because this should be a tool in a toolbox. This shouldn't just be the whole toolbox. Like, you should have regular follow-ups. You should be staying like on top of it, feeling responsible for your choices, and working with a provider to keep you, responsible.
Yeah, that's a great one for sure. Okay, just jumping back into the GLP-1s specifically, I know we kind of addressed this with general peptide therapy, but are there people in particular that are just not at all good candidates for GLP-1s? I know obviously you mentioned if you have diabetes or if you have a certain history of, pancreatitis, I think it was. Anybody else? And like, are you treating people who are not technically overweight with GLP-1s as well? Like, if you're looking at BMI, which I know is outdated for a lot of people, so just kind of in terms of like who is a good candidate for them, and also what other benefits do you see when people go on these GLP-1s? Like, are you using them as an additional tool in the toolbox to treat other things like inflammation as an example?
Okay, so first of all, in diabetes, GLP-1s are great. I was just saying that you are at more risk adverse to having like the diabetic retinopathy. So just something else to like look at. Um, People who are not good candidates are if you're pregnant, breastfeeding, because we don't know how it goes through the milk. If you have an eating disorder, not a good candidate. I If you have had a history of pancreatitis, gallstones, or like severe gastroparesis or GI like motility issues. Um, and I don't love patients who come in who don't want to make any changes, work for it a little bit. That is kind of a bad candidate for me. So I don't just go by like BMI. If you're overweight, oh, sure. I take a full panel and I look at your blood work. It's amazing for inflammation, it's amazing for endometriosis, PCOS patients, it's amazing for, the blood sugar control part of it. So, any like, if your fasting insulin is high, your IR score is high, all of these things the GLP-1s are helping. So I kind of look at the whole picture and not just at your weight, because there's more to it than your weight. I say to people all the time, like, you skinny fat. I have these skinny patients who come in and their blood work, they are so metabolically dysfunctioned based off of their lab work. And then they start telling me about how they eat and whatnot. And I'm like, this is bad, because your metabolic health, if you take one thing from this talk, besides like the peptides and all the things I do, your metabolic health is the key to longevity and not getting chronic disease and living a long, healthy life. So your gut is where everything comes from. And so being metabolically fit is the best thing you can do. And GLP-1s do help get you more metabolically fit because they help control those blood sugar spikes.
So when you say metabolically fit, what are the markers specifically that you're looking at that contribute to that picture of health?
I think I went on a tangent. I'm sorry.
No, no.
No. So what I look at, I'll look at your IR score, so making sure you're insulin sensitive and not insulin resistant. I'll look at your hemoglobin A1C and actually look at that number. So not just if you're in the prediabetes range, but how close are you to the prediabetes range? I'll look at your fasting glucose. I'll look at your fasting insulin. I'll look at some inflammation markers. I look at something called your sex hormone binding globulin. That's another sign of how metabolically fit you are. Your ferritin. I think that about covers it.
And I think what's great about providers like you, Rachel, is you're not looking at the range that's given and you're saying, oh, you're within the range. Like you are truly looking at optimal numbers, because sometimes the range can be so wide and the range can be so large that it's like, if you're on the low end versus the high end but still within range, like you can feel very different. So to me, I feel like the measure of a great provider is somebody who's always coming in and saying, yeah, you're within range, but this is where you need to be in order to feel better. So I think that's always a great addition. We have one more question that came in. I know this is very patient specific, but what is a rough range for an average expected yearly cost for a patient on peptide therapy? Let's assume they're only on one peptide, because this person is assuming that most insurances don't cover the peptide therapy, I guess, outside of GLP-1. So just other peptides, like what would you say? Can you give us some rough costs of maybe what some of the most typical peptides that you're recommending would cost yearly?
Yes. So yearly, I would have to think about it for a minute. But like, for example, depending, like, I would say to be on BPC 157 for a whole year, but remember, you're not going to be on it for a whole year because you're going to cycle it, would be around $1,000 to $1,200. And that just depends on the dose, what you're using it for, how frequently you're using it. So it's like hard to give a number, but peptides are not inexpensive. They're not covered by insurance. There's a couple that are, but in terms of these ones not covered by insurance, you kind of have to look at it like when you go and buy a bag, that's a materialistic object. This is, you're investing in your health. So it's a different like mindset that, you have to decide if that is a priority to you or not. Again, I would say like for one peptide for a year, and like again, every peptide costs different, and it's usually you need more than one peptide, and we come up with a whole plan. I would say 1,000.
And then one more quick question before we move on to BHRT. NAD. So it's not a peptide, right? But it is an injectable. And that is also something we keep hearing about. So can you just talk a little bit about that and like how you would cycle that in, for longevity, anti-aging?
There we go. Okay. Yes. So I love NAD. NAD is not a peptide, but most providers kind of put it together to in the peptide category, which like technically is not right. So NAD, the full word of it, I'm going to butcher it, so I'm not even going to say it, but if I get too scientific, let me know. But if you remember back to science class, in each of our cells, we have something called the mitochondria. And the mitochondria is like the powerhouse of the cell. It's what does everything to get everything working. And to get the mitochondria to work, you need ATP, which is energy. And the ATP is what gives energy to the mitochondria to have the cells work. Now, a precursor to ATP is NAD. So as we get older, our NAD levels just continue to decrease. And so by doing NAD, you're increasing that level, which is increasing how much ATP you have, which in doing so helps your mitochondria work better, which in doing so helps all your cells in your body function better. So NAD, if you're taking it orally, throw it out. It doesn't do anything. Don't waste your money. It needs to be injected. For the most part, there's a couple liposomal ones that you could fight me on, and I would tell you, okay, maybe this does work, but it should be either an injectable, like subcutaneous injection or IM injection, or an IV. I personally like doing protocols of 10 weeks with NAD, and I cycle it a few times throughout the year. You do it twice a week. And that helps bring your NAD levels up. And in doing so, you feel better. You're less fatigued. You sleep amazing. Your skin is great. You recover better from workouts. I'm obsessed with NAD. I think it's the reason why my skin looks so clear. When I don't take it, I'm like, what is happening? And then I take it and my skin's clear. So that is a selling point for me for sure.
I feel like I'm really missing out now. I know I didn't pick that one up when I was there, but that's on my list for next time. So I'd love to try that. Okay. Feel free to still ask if you guys have any questions on peptides in general or GLP-1s, but I want to just move into BHRT, so bioidentical hormone replacement therapy. Also, all the rage these days. So we're covering all the hot topics. Huge announcement, which I shared on our socials that Rachel had posted, which is the FDA removing the black box warning on bioidentical hormone replacement therapy, BHRT. My mother was unfortunately a victim of this back in the day. After she had me, she was put on HRT and then subsequently taken off when this study came out that was, as you said, severely flawed and kind of did a huge disservice to a lot of women in kind of taking them off of hormones. And she has definitely seen the effect of not having been on those longer term now. So I think with that, obviously more and more people are talking about it. More and more people are going to start kind of moving into this realm and, as practitioners. So we want to talk a little bit about, what is BHRT, which I think we've kind of covered, but, and yes, the question that just came in, progesterone is considered hormone replacement therapy. So Rachel will talk a little bit about like hormone replacement therapy versus bioidentical. So if you can kind of like just go over that distinction quickly, Rachel, and just anything else you want to add kind of as a general statement on BHRT, that would be awesome as a starting point.
Awesome. Love this topic. Okay. So hormone replacement therapy and then BHRT is bioidentical hormone replacement therapy. So hormone replacement therapy includes synthetic hormones such as birth control. Bioidentical hormones is natural, what your body is lacking, not synthetic. So for example, progesterone comes from yams. So when we talk about HRT versus BHRT, that flawed study was actually about HRT, looking at synthetic progestin. That can cause an increase in blood clots and cancer risk in an extended period of time. Again, synthetic hormone replacement. When we look at bioidentical hormone replacement therapy, estradiol, testosterone, progesterone, microionized progesterone, thyroid, all of those are safe. They are giving your body what you are lacking and what you're becoming deficient in. And the long-term data of being on these hormones is actually insane as to what it is preventative of. So it's preventative of heart disease. It's preventative of dementia by 60%, which like, why does no one talk about that? Because that's huge, how protective it is of your brain and your bone health. So estradiol, being deficient in estrogen, is what causes osteopenia, which causes osteoporosis, which is the demise of so many women as we get older. You hear of someone who broke a hip and they never recovered, and that's because of the osteoporosis that formed from not having those hormones in their body. I forgot what I was just gonna say, so I'm gonna mute it.
I know there's so much to say about this. It's just fascinating to me, and there's like so many questions. So first off, one of the myths and one of the things that, well, I don't know if it's a myth. I keep hearing once you go on it, you cannot go off of it. Your body is going to stop producing these hormones on their own. What do you have to say to that?
So you can go off of it whenever you want. I tell patients this pretty much every day. Once you go off of it, nothing bad's going to happen because it's bioidentical hormone replacement therapy. So it's just going to take you back to your natural levels. It's not suppressing your body's ability to make hormones. Like synthetic birth control stops your body from making certain hormones. When we talk about bioidentical hormone replacement therapy, it's just refilling, giving more of what your body is lacking in. So when you stop it, nothing bad is going to happen. You're just going to go back to where you were before. So I am always a proponent of staying on it because of the long-term effects of the hormone therapy, the bioidentical hormone therapy. However, if you want to go off of it, nothing bad's going to happen. You're just going to go back to where you were.
Can you talk a little bit about a standard case? Like, let's just say, no major kind of anomalies in a case of a patient. what would a typical BHRT path look like? Like starting at what age with what hormones? And I know that might be hard to say. So just maybe take more of a typical case, what you would see, and like when would you start testosterone, when progesterone, when estradiol, and like how would that progress throughout their like perimenopause and then menopausal journey?
Okay. So testosterone is the first hormone to decrease. It decreases in your late 20s. And with our environment, toxins, we're seeing like people are becoming deficient, both females and males, in testosterone at much younger ages. So testosterone in men should not be given until they're done having kids because it can impact fertility. Women can go on it and then go off of it 3 months before trying to conceive, just as like a caveat. So the first thing to I give a patient usually is testosterone. Then in our mid 30s, once we start to get some more hormone shifts and creeping into that perimenopause stage, progesterone's decreasing. And estrogen and progesterone are normally on a seesaw. As one spikes, the other one decreases, and they work in tandem. And what happens is that progesterone decreases, and when it decreases, you get all these symptoms of like excess estrogen. So your periods start to change. They can get shorter in between times, heavier, more clotting. We get mood changes, abdominal weight gain. This is all from low progesterone. So I supplement my patients with progesterone. I don't touch estrogen. And this is where I differ again with a lot of providers. I do not touch your estrogen. I do not give a patient any form of estrogen until they are menopausal. And what that means is 1 year without menses, period. Because your estrogen is all over the place during perimenopause. And when you give estrogen to a patient that is perimenopausal, still getting their menstrual cycles, however infrequently or however that may look, you can get excess estrogen, and that excess estrogen causes more harm than it does good. And that can look like bleeding, bloating, breast tenderness, acne, and bitchiness are like the 5 B's of estrogen dominance. So I do not supplement estrogen until you are menopausal. Progesterone, bring it on as early as you have symptoms. Let's bring it on because it's so helpful with sleep, that abdominal weight gain, mood, all of that. Getting your cycles more regular again, all of that is fixed with progesterone.
Yeah, it's really fascinating, and I've started this journey as well, and, just with the testosterone and now the progesterone, and I will say last night specifically, I got 5.5 hours of sleep, and almost 2 hours of that was deep sleep. And it has to be from the progesterone because I track this stuff like crazy on my Aura Ring, and I was like, "Wow, that is." It's just so cool when you can kinda see that direct effect, and it's hasn't even been that long, but I feel like I'm already kind of seeing the effect of it. So, I mean, and I keep telling people, you don't realize how badly you felt or how much, because obviously I've been doing the peptide therapy and now I'm on the BHRT. I did not realize how bad I felt until I felt better. I knew I felt bad, but I didn't realize how extreme it was until I felt better. And so it really has, I mean, I guess I'm the reason for that headline, like feel better than you even did before. Because it really has made a difference for me. And so, like in people's cases, like my mom, who is like about to turn 70, what would you say to them? Those women who are past menopause, like, is it too late for them to start BHRT? Like, because I had heard some reports that maybe once you start after your menopausal, that it can actually have a negative effect. Like, is that true? Like on the heart disease, like some of those like positives that you had mentioned in those preventative kind of aspects of it.
So it's never too late to start BHRT. I do tell patients that if you are starting that much later, you are missing some of the benefits, but nothing bad will happen. I also tell patients that like if you're 70 and if you're 70 and you have been menopausal, for 20 years, you're going to feel a little crummy before you feel good because all of those hormone receptors, which are throughout our whole body and our brain and our gut, everywhere, have been so turned off, and so I'm slowly turning them back on. So I tell patients you got to give it a month because it's going to take a minute before you feel good.
Okay, that makes sense. I mean, that's great to hear. So she might be coming to see you. So you talked a little bit about thyroid, and I know we have thyroid hormones as well. Please tell me why it seems like everybody's thyroid is tanking nowadays. Like, is that also something that just deteriorates as you hit like 40 and beyond, or is it environmental? Is it both? Like, why do I feel like now everybody all of a sudden is having like thyroid symptoms?
So your thyroid is a very complex organ, gland, and so basically when everything is disrupted, your thyroid is being disrupted as well. So your cortisol, your stress levels, the way if you don't have any muscle mass, all of that is impacting your thyroid. I also strongly believe that there's a large correlation between like our environment, our toxic load, all of that that's playing a role on why our thyroids are so like dysfunctioning. If your gut is bad, you're not going to convert T4 to T3, and T3 is like the active thyroid hormone. So that's kind of why we're seeing, are we seeing more of it, or are we just like learning more and more aware of it? I'm not positive about that, but in terms of thyroid, it's all interrelated. So if you're not optimized hormonally, your gut, have healthy lifestyle, healthy eating, working out, all of that, muscle mass, your thyroid's tanked. Stress is a huge factor of that as well.
So if somebody was in a, and we have a question I'll get to in a second. If somebody's gut was a mess and so their thyroid was a little bit low, but then they heal their gut and they go on hormones, could they presumably then stop taking the thyroid? If they're taking like that, bioidentical or the desiccated porcine thyroid, not like a synthetic thyroid hormone, could they then go off of that? Like, would the thyroid then presumably get back to better levels, or do you see that they kind of have to remain on the thyroid medication, more indefinitely?
So everyone's kind of a different case. It kind of depends on what else I see. Some people I can get off their thyroid medication. Some people have to stay on it. It just kind of depends what else is going on. And then also like there's different vitamins, like different trace minerals that are very supportive of a healthy thyroid, selenium, zinc, iodine, all those. So that can help as well.
Got it. Okay, the question that came in, I know that this is gonna be a little specific, but if there's anything, that you can offer to this, just feel free to share. But, this person just started progesterone, just had her first period on it, and she's finally not having super heavy periods, which is great. She lost 5 pounds, but PMS is still raging. She's sleeping a little bit better. She's asking, do you think that means she should be on a higher dose, or is there maybe kind of an adjustment period? What do you think might be happening without knowing her specific history?
Yeah. I mean, there is an adjustment period. I would have to see what else is going on, what else you're taking, what all the rest of your levels are looking. But sometimes, yes, you do need a little bit more progesterone.
Got it. And then the last question I had, and again, feel free, we have a few more minutes if anybody has any other questions, is just around, prior to entering this journey, I was always looking at, supplements and other kind of natural approaches to supporting. Why is it that those are not enough at this point? Is it just that I have maybe too much of a deficit that needs to be made up? I mean, I know you're using like some natural supplements kind of complementary to this plan, but what is your take on like why we can't naturally increase these using other methods? Like I know testosterone can be increased by strength training. Is it just not enough for the kind of deficit that we're looking at this point in our lives?
So first of all, I think like in the past, like our parents' generations, people didn't talk about things like we talk about things. So they kind of just went through with the way they were feeling and kind of left it at that. Nowadays, like we're all very vocal and, want to kind of get to the bottom of things. So the issue with hormones is that at the end of the day, it's biology. Your hormones are going to decrease as you're going through these changes in womanhood. And so the best, most influential way to fix that is just by giving yourself exactly what you're lacking. Supplements, peptides, all of that is great addition. But at the end of the day, like what menopause means is that you are no longer making those hormones. And like no supplement is going to fully get you back to when you were making those hormones. So that's why bioidentical hormone supplementation is so critical.
Okay, we had another question come in. It says, I eat well, I'm active, I fast, I don't drink alcohol, yet I cannot lose weight for the life of me. In fact, she's gaining. Could this be because I've not yet reached menopause, but I'm using the estradiol patch? Would it be safe to stop the estradiol to see if that makes a difference?
100%. Yep. And don't want to give medical advice on this, but yes, that's why we don't like estradiol patches in patients who aren't menopausal.
Makes sense. And so just because I have heard it from multiple people. So you're saying the body does not stop naturally producing hormones when you're on BHRT. It it just supplements and your body kind of maintains what it was producing, but then the BHRT comes in on top of.
Yes, ultimately your body will stop,
Will stop on its, yeah.
but it's not suppressing what your body is making, as opposed to like an oral birth control does suppress your natural ability to make the progesterone and estrogen as you were. So it's 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 not affecting your initial natural hormone production.
Yeah, yeah. Oh, look, I'm not echoing anymore. Just as we're
Oh,
about to sign off.
yay.
Um, sorry. Okay. Any final questions, you guys, please submit. I know we covered this with peptide therapy, but best practices, best, things to look out for in a BHRT provider. I think blood work is huge, as you said. Same with that. Like I have a friend who's going somewhere and she went on BHRT just from her OB and she was feeling good. And then all of a sudden it's like she relapsed and was not feeling good at all. And I was like, well, how did your levels adjust? And she's like, well, I don't know. They didn't take her blood. And so what I've learned in this process through you and through other providers is like absolutely look for somebody who is testing your blood regularly to see that, how where your levels are because they can fluctuate. I mean, I'm sure you would agree, Rachel. Anything else that you would add?
Yeah, just I think now that this black box warning has been lifted, there's a lot of people are going to be popping up prescribing hormones. So just making sure you're finding a provider who's trained, knowledgeable, knows what they're doing, has been doing this for a little while. And then, yes, like blood isn't the whole picture, but if you're not testing blood and you're just prescribing, I'm trying to think of there's some company online that I have a lot of patients who come to me and they're like, they can't prescribe testosterone, but they put me on X, Y, and Z. And I'm like, but they've never seen your levels. And they're like, no, they don't draw blood. I'm like, okay. Um, Probably not the way to go. So, being an educated advocate for yourself, making sure you look at the whole picture and you do all the things, and that you find a provider who like really, really just educates you and works with you and you know, is your partner in this, because this is, a long shift in the way you feel and what is going on in your body, and just having someone that you can work through this together, because every person's different, is really important.
Yeah, and that's what like even the provider I'm working with now and I've started working with Rachel as well. I just so appreciate that I don't feel judged. I don't feel like I'm offending them when I come in with, my own thoughts because I just have learned not from my experience with you or anybody else, but I do need to be my own advocate and I do need to do my own research and sometimes it makes life a little bit more difficult because there's just more confusion and more overwhelm, but if you find the right provider, they can help you navigate that. They won't judge the million questions that you might have. And of course, it's all in how you present it too. Like I'm not coming in being like, well, Google told me this, and kind of assuming that Google is going to be smarter than your lived experience. But yeah, I think that's so important. And I've appreciated that working with you so far as well. We have another submission. It says, I'd love to start a peptide, but is there an onboarding cost? So can you just talk a little bit, Rachel? And I'm sorry if you covered this a little bit in the beginning when I was working through the technical issues, but what is kind of the structure of how people can work with you whether it's hormone patient or peptide patient or both. If you can just kind of go over that.
So I have a bunch of different like ways to look at this. So I just recommend a consult. My consults are free, so when you come in, we'll talk about it. I'll give you all the options. I try to make it as like affordable and as manageable for patients as possible. I don't have an onboarding cost, but like just to do peptides, which isn't my biggest recommendation, you should do the whole picture. But a patient who just wants to do hormones, I usually have like a managing care fee for the year of $250 just for all the time and working together. I'm very available. I give you my cell phone. I'll talk to you whenever you need type thing. So just for my time basically. And then for everyone on this call, if you mention it, like I have no problem giving 10% off of the cost to get started.
Thank you. That's awesome. You guys, that's fantastic. Honestly, I wish I had found Rachel sooner. Not that I don't like my current provider, but I think that's such a great, accessible rate to kind of get into this. And again, the peptides are not cheap, but you just want to make sure that you get a very qualified provider like Rachel who knows what they're talking about, who you can trust, that isn't, a fortune to just work with her. And so that you're very targeted. So that person is very happy. She said, that's amazing. Thank you. One more quick question. Sorry. This is actually for me. I've always wondered about adrenal fatigue. Like, how do the adrenals play into this? And how do I know if I just need to like nurture my adrenals to help in turn nurture my hormones? Or is it like some people believe adrenal fatigue is just kind of a phrase and it's not a real thing. So what's your take on that?
So your adrenals are what make cortisol. And so I do test cortisol because that could be playing a role in a lot of things. It's your fight or flight hormone. So that's another like part of the whole picture that we look at.
Okay. So we need to look at that when I come over. It's a full time because I'm just curious what role that plays in it. So awesome. We had so many great questions, so much interaction and engagement. Is there anything else you want to add, Rachel, that we didn't cover off on? I feel like we covered quite a bit.
Yeah, no, if anyone has any questions, you can reach out to me. I'd love to see you guys and help you feel better.
Awesome. Thank you again so much for joining us, Rachel. And it's just been a pleasure to work with you so far. And I'm so grateful that you came on. And I hope people will come see you or anybody really. I mean, I'd love for you to see Rachel, but just any help you can get to feel like yourself again. I would love to. I feel so much better and I want other people to kind of experience the same thing. And thank you all for bearing with us through the technical issues in the beginning. You as well, Rachel, for the mute unmute dance that we did. And the recording will be posted on the platform as always. And if you have any follow-up questions, as Rachel said, she's very accessible. Another participant just said thank you. She's very accessible for like a quick consult just to kind of see if it's a good fit for you. And she is on Nore as well. So you could, message her there if you wanted to reach her there as well. But she's also at Be Well. So that number is listed on the event post if you want to reach her through Be Well Lifestyle Centers out of Birmingham. So thank you again, everybody, for joining. Thank you, Rachel, and we'll chat soon.